article, this is taken from by which is written by UCSD School of Medicine and VA Medical Center, San Diego, California. So the major elements of the cardiovascular examination include observation, palpation, and auscultation. So as with all other areas of the physical exam, so assessing adequate exposure and quiet environment or critical. So initially the patient should rest supine. Patient should be supine. Body should be elevated 30 to 45 degrees. So most exam tables have an adjustable top. If not, use 2 or 3 pillows. So remember that although assessment of pulse and blood pressure are discussed in vital signs section, they are actually important elements of the cardiac exam. So the evaluation of the cardiovascular system focuses on the heart, but it should also include the assessment for disease in the arterial system throughout the body. Not only on the heart, but examination should also include assessment for disease in the arterial system throughout the body. So atherosclerosis, the most common cardiovascular ailment in the Western world, is a systemic disease. So assessment for disease in the arterial system throughout the body has to be done, because atherosclerosis, it is the most common cardiovascular ailment in the Western world. And then observation. So first is assessment for distension of the right internal jugular vein. It is a difficult skill. So its importance lies in the fact that internal jugular vein, no, so this is in straight communication with the right atrium. So this internal jugular vein and right atrium, it has got a straight line communication. So because of this, the internal jugular vein, it functions as a manometer. Internal jugular vein and right heart has got a straight line communication. So this internal jugular vein therefore functions as a manometer with distension indicating elevation of central venous pressure. So if this IGV is distended, so this indicates that there is a elevation of the central venous pressure. So this in turn is an important marker of intravascular volume status and related cardiac function. So that is why if we examine the JVP, so this it's an important intravascular volume status will be there, no? So it's an this JVP is an important marker of intravascular volume status and related cardiac function. So this IJ, so this internal jugular vein, no, it's direct communication with the right atrium. So discussion of A, C and V waves, no, that make up the jugular venous pulsations can be found elsewhere. So these are quite difficult to detect for even the most seasoned physician. So why is jugular vein distension so hard to assess? So this internal jugular vein, no, so it is lying deep to skin and soft tissues. So where is this internal jugular vein? It is lying deep to skin and soft tissues, which can provide quite a bit of cover. So additionally, this blood vessel is under much lower pressure than adjacent pulsating carotid artery. Okay, so it's lying deep to skin and soft tissues, and this blood vessel, no, it is under much lower pressure. Internal jugular vein is much under lower pressure than the adjacent pulsating carotid artery. So therefore it takes a sharp eye to identify the relatively weak transmitted venous impulses. So because of this, it takes a sharp eye to identify the relatively weak transmitted venous impulses. So there are a few things to remember. So think anatomically. First, think anatomically. the right internal jugular vein, it runs between the two heads, that is sternal and clavicular head of the sternocleidomastoid, and up in front of the ear. So this is the line that you have to remember. The right internal jugular vein, no? The right internal jugular vein runs between the two heads. So what are the two heads? Sternal and clavicular head of the sternocleidomastoid. It is running between the two heads of the sternocleidomastoid, between the sternal and clavicular head of sternocleidomastoid muscle, and up in front of the ear, and up even in front of the ear. Okay, so this muscle can be identified by asking the patient to turn their head to the left. So patient is turning the head to the left and into your hand while you provide resistance to the movement. So at the same time, your patient is turning the head and your hand is providing resistance to the movement. So these two heads, no, they form a small triangle with the clavicle making up the bottom edge. So because of this will be the sternal head and this will be the clavicular head. So these two, they form a small triangle with the clavicle making up the bottom edge. You should be able to feel a shallow defect formed by the borders of these landmarks. So clavicular head and sternal head, there will be a small triangle and bottom will be the clavicle. So there will be a shallow defect formed by the borders of these landmarks. So note, you are trying to identify impulses originating from the internal jugular vein, and these impulses are transmitted to the overlying skin in this area. So what are you trying to identify? You are trying to identify the impulses originating from the internal jugular vein and transmitted to the overlying skin in this area. You can't actually see the internal jugular vein. You can't actually see the internal jugular vein. You are just trying to identify the impulses originating from the internal jugular vein. The external jugular vein, it runs in an oblique direction across the sternocleidomastoid, and in contrast to the internal jugular vein can usually be directly visualized. So this here, no, here you can see the external jugular vein. So the external jugular vein runs in an oblique direction across the sternocleidomastoid, and in contrast to the internal jugular vein, so this can be directly visualized. If the external jugular vein, if it is not readily apparent, have the patient to look to the left and a Valsalva manner. So if the external jugular vein, if it is not readily apparent, then have the patient do the left and do a Valsalva manner. So this usually makes it quite obvious. External jugular distension, it is not always an indicator of elevated central venous pressure, as walls designed to prevent the retrograde flow of blood can exist within this vessel, causing it to appear engorged even when central venous pressure is normal. So if we see the external jugular vein distension, so this is not always an indicator of elevated central venous pressure, as walls, no, designed to prevent the retrograde flow of blood can exist within this vessel, causing it to appear engorged even when central venous pressure is normal. So because of the walls, they can exist within this vessel, and these walls are causing the external jugular vein to appear engorged. It also makes several turns prior, so it's not in straight line communication. So this external jugular vein makes several turns trying to connecting with the central venous system, and thus not in a direct line with the right atrium. So sternal head of sternocleidomastoid clavicle and clavicular head of sternocleidomastoid, path of internal jugular vein and external jugular vein. Okay. Take your time. Look at the area in the question for several minutes while the patient's head is turned to the left. So patient's head is turned to the left. So look at the area. And the carotid artery is adjacent to the internal jugular vein, lying just medial to it. So which artery is lying adjacent to the internal jugular vein, lying just medial to it? So carotid artery, it is adjacent to the internal jugular vein, and this carotid artery, it is lying just medial to it. If you are unsure whether a pulsation is caused by the carotid or the internal jugular vein, if you are unsure whether a pulsation is caused by the carotid or the internal jugular vein, place your hand on the patient's radial artery and use this as a reference. So if you are unsure whether it is carotid or internal jugular vein, you place your hand on the patient's radial artery and compare the pulsations. So the carotid impulse coincides with the palpated radial artery pulsation. Carotid impulse, if it is a carotid artery, no, so that impulse coincides with the radial artery pulsation. So this is characterized by a single upstroke timed with systole. So with systole, no, there will be a single upstroke timed with systole. There will only be a single upstroke. It is timed with systole. So during that systole, no, so that upstroke occurs. So it's a single upstroke timed with the systole. So the venous impulse, at least when the patient is in sinus rhythm and there is no tricuspid regurgitation, it has got three components. So then the venous impulse. So this venous impulse, so at least when the patient is in sinus rhythm and there is no tricuspid regurgitation, it has got three components. So each associated with the A, C and V waves. So when these are transmitted into the skin, they create a series of flickers. So when these A, C and V waves, when they are transmitted to the skin, they create a series of flickers that are visible diffusely within the overlying skin. In contrast, the carotid causes a single up and down pulsation. Carotid is causing only single up pulsation and down pulsation. But this venous impulses, they will cause a series of flickers that are visible diffusely within the overlying skin. The carotid, furthermore, the carotid, it is palpable. Carotid, we can palpate the carotid, no? The internal jugular vein is not and can in fact be, see this internal jugular vein impulse, it can be obliterated. That is when you try to press, no, what will happen? It can be obliterated as by applying pressure in the area where it emerges above the clavicle. So search along the entire projected course of the internal jugular vein as the top of the pressure wave. So search along the entire projected course. So that is the entire projected course. So this course, this line is there, no? So from here, so this is the entire projected course. So search along that entire projected course of the internal jugular vein as the top of the pressure wave, which is the point that you're trying to identify, may be higher than where you're looking. So that is why you have to search the entire projected course. In fact, if the patient's central venous pressure is markedly elevated, you may not be able to identify the top of the wave unless they are positioned with their trunk elevated at 45 degrees or more, else there will be no identifiable top of the column as the entire internal jugular vein will be engorged. So if patient's central venous pressure If it is markedly elevated, you may not be able to identify the top of the wave. So because of that, the trunk should be elevated at 45 degrees or more, else there will be no identifiable top of the column, as the entire IJV will be engaged. So after you have found the top of the wave, see what effect sitting straight up and lying down flat have on the height of the column. So once you have turned the head, you have identified the top of the wave, and then make the patient sit straight up and then lying down flat, and then you see what effect it has got on the height of the column. Sitting should cause it to appear at a lower point in the neck. So if we ask the patient to sit, no, so that will cause JVP to be elevated at a lower point in the neck. And supposing if the patient lies down, no, so the JVP will be at a higher point. So sitting lower point, lying JVP will be at the higher point. Realize that these manias do not change the actual value of the central venous pressure. So sitting or lying, no, so the actual value of the central venous pressure is not changed. They simply alter the position of the top of the pulsations. What does they alter? They alter the position of the pulsations in relation to other structures in the neck and chest. So shine a pen light tangentially across the neck. So this sometimes help to accentuate the pulsations. Okay, just shine a pen light tangentially across the neck. So this sometimes help to accentuate the pulsations. If you are still uncertain, apply gentle pressure to the right upper quadrant of the abdomen. So if you are still uncertain about the pulsations, what you have to do, you have to apply a gentle pressure to the right upper quadrant of the abdomen for 5 to 10 seconds. So this elicits hepatojugular reflex, which will cause blood that is within the so this elicits hepatojugular reflex, which will cause blood that is within the liver, a highly vascular structure, to flow in a antegrade fashion and fill out the internal jugular vein. So because of this is eliciting the hepatojugular reflex. So this will cause blood that is within the liver. Liver is a highly vascular structure, so it will flow in an antegrade fashion and it will out the internal jugular vein. So this in turn makes the transmitted pulsations more apparent. Because of this hepatojugular reflex, the transmitted pulsations are becoming more apparent. Make sure that you are looking at the correct area when you push, as the best time to detect any change in the height of the column of blood is immediately after you apply the hepatic pressure. So you are immediately applying the hepatic pressure and you are looking at the correct area. So once you identify the jugular vein distension, to estimate how high in centimeters the top of the column is above the angle of Lewis. So what you have to measure, so you have identified the jugular vein distension. So then what you have to do, so you have to estimate, so from the above the angle of Lewis, okay, so here this is the angle of Lewis, that is at the sternum and manubrium junction. You have to estimate how high in centimeters the top of the column is above the angle of Lewis. So the angle is the site of the joint. So what is this angle of Lewis? Nothing but this angle which connects the manubrium with the rest of the sternum. So this manubrium is getting connected to the rest of the sternum. So the angle is the site which connects the manubrium with the rest of the sternum. So first identify the suprasternal notch. So this suprasternal notch, so it is a concavity at the top of the manubrium. So first identify the first to identify this manubrium. Now first identify the suprasternal notch. So this you can easily identify a concavity at the top of the manubrium. So then walk your fingers downward until you detect a subtle change in the angle of the bone. It's approximately 4 to 5 centimeters below the suprasternal notch. So this is roughly at the level of the second intercostal space. So after you identify the manubrium sternum, so the vertical distance from the top of the column to this angle is added to 5 centimeters, the rough vertical distance from the angle to the right atrium with the patient lying at 45-degree angle. So you are calculating the vertical distance from the top of the column to this angle, and then we are adding 5 centimeters. So this 5 centimeters, why we are adding? Because it is the vertical distance from the angle to the right atrium. So when the patient is lying at 45 degrees angle, we are measuring the top of the column to the manubrium sterni, and then we are adding 5 centimeters. So this will provide this is something, the distance from angle to the right atrium. So this 5 centimeters is the distance from the angle to the right atrium. So this sum is an estimate of the, so this sum, no, so this is an estimate of the central venous pressure. However, if you can simply determine with some accuracy whether a jugular vein distension is present or not, you will be way ahead of the game. So normal central venous pressure is 7 to 9 centimeters. How many centimeters? 7 to 9 centimeters. So angle of Lewis, sternal manubrium junction, clavicles, manubrium, sternum and second rib. Angle of Lewis, manubrium, sternum, clavicle. The wooden Q-tip highlights the different slopes of the sternum and manubrium. So the point at which the Q-tips cross is the angle of Lewis. So CVP 5 centimeters plus this height, assuming the top. So here videos are given, video stimulation and discussion of the central venous pressure. And then there are several sources of tension relating to the physical exam in general, which are really brought to the fore during the chest exam. So these include area to be examined must be reasonably exposed, yet patient kept as covered as possible. So the need to palpate sensitive areas in order to perform an accurate exam requires touching people whom you have little acquaintance, particularly of opposite gender. So as newcomers to medicine, you are particularly aware that this aspect of the exam is unnatural and hence very sensitive. So keys to perform a sensitive yet thorough exam. Explain what you are doing and expose the minimum amount of skin necessary. Examine heart and lungs of female patients. Expose left side of chest to extent needed. Enlist patient's assistance and don't rush, act in a careless fashion. And then the palpation. So in the palpation, the palm of your right hand is placed across the patient's left chest so that it covers the area over the heart. If you place your palm over the patient's left chest, it covers the area over the heart. So the heel should rest along the Sternal border. Where should the heel rest? Heel should rest along the sternal border with extended fingers lying below the left nipple. Okay, heel is resting along the sternal border. Extended fingers, no, they are lying. Extended fingers are lying below the left nipple. So heel is resting on the left sternal border. Extended fingers are lying below the left nipple. So you have to focus on several things. Can you feel a point of maximum impulse related to contraction at the apex of the underlying left ventricle? So can you feel a point of maximum impulse? Heel along the sternal border, extended fingers below the left nipple. So can you feel a point of maximum impulse related to contraction at the apex of the underlying left ventricle? If so, where is it located? So after identifying the rough position with the palm of your hand, so you have identified the rough position with palm of your hand. So try to pin down the precise location with the tip of your index finger. So you have to try to pin down the precise location with the tip of your index finger. So the normal sized and functional ventricle will generate a penny sized impulse that is best felt in the mid clavicular line. So how is the impulse? It is a penny sized impulse best felt in the mid clavicular line, roughly at the fifth intercostal space. Best felt in the mid clavicular line, so it's a penny sized impulse. If the ventricle becomes dilated, most commonly as a result of past infarcts and always associated with ventricular dysfunction, the point of maximal impulse is displaced laterally. So if the ventricle is becoming dilated because of the past infarcts and always associated with ventricular dysfunction, the point of maximum impulse is displaced laterally. In cases of significant enlargement, the point of maximum impulse will be located near the axilla. If there is a significant enlargement, no, the point of maximum impulse will be located near the axilla. Occasionally, the point of maximum impulse will not localize to any one area, which does not necessarily indicate ventricular enlargement or dysfunction. Obesity and COPD may also limit your ability to identify its precise location. Obesity and COPD, no, it may also limit your ability to identify its precise location. So palpating while the patient is in the left lateral decubitus position can make the point of maximal impulse more obvious. So if you have to palpate the patient, if you have to palpate the point of maximum impulse, patient has to be in a left lateral decubitus position. And what is the duration of the impulse? What is the duration of the impulse? So in the setting of hypertension or any other state of chronic pressure overload, the ventricle hypertrophies and the point of maximum impulse becomes sustained. That is, you feel the impulse for a longer period of time. So this is actually pretty subjective and can be tough to detect. So what is the duration of the impulse? So in the setting of hypertension or any other state of chronic pressure overload, the ventricle hypertrophies and the point of maximum impulse become sustained. You feel the impulse for a longer period of time in cases of hypertension or a state of chronic pressure overload. So this is actually pretty subjective and can be tough to detect. Note that hypertrophy and dilatation are not synonymous. Dilatation and hypertrophy are not synonymous. They can exist separately or in conjunction with one another. So how vigorous is the transmitted impulse? So, process associated with ventricular hypercontractility, that is, compensated mitral regurgitation or aortic insufficiency, that results in exceptionally large stroke volumes, generate an impulse of unusual vigor. And you feel a thrill. So, what is this thrill? It's a vibratory sensation produced by turbulent blood flow that is usually secondary to valvular abnormalities. So, feel a thrill. It's nothing but a vibratory sensation produced by turbulent blood flow that is usually secondary to valvular abnormality. So, the feeling is similar to that produced when you squeeze on a garden hose, particularly obstructing the flow of water. The location of the thrill will depend on the involved wall. That is, thrills caused by aortic stenosis are best felt toward the right upper sternal border. So this is the location of carotid arteries. So the location of the thrill, no, it will depend on the involved walls. Supposing if thrills caused by aortic stenosis, no, they are best felt towards the aortic stenosis thrills right upper sternal border. If a loud murmur is detected during auscultation, you may then go back and reassess for the presence of a thrill. In general, thrills are an uncommon finding. Palpation of the precordium of a female patient is best done by placing the palm of your right hand directly beneath the patient's left breast such that the edge of your index finger rests against the inferior surface of the breast. Make sure that you tell that patient what you are about to do before actually performing this maneuver. And remember that with age, tissue turgor often declines, causing the breast to hang below the level of the heart. And then carotid artery palpation. Palpating the carotid artery, this is of greatest value during the aortic valvular and outflow tract disease, and should thus be performed after auscultation so that you know whether or not these problems exist prior to palpation. However, for the sake of completeness, it will be described here. So the carotids can be located by sliding the second and third finger of either hand. Which finger? Second and third finger of either hand along the side of the trachea at the level of the thyroid cartilage. Along the side of the trachea at the level of the thyroid cartilage, that is Adam's apple. So the carotid pulsation is palpable just lateral to the groove formed by the trachea and the surrounding soft tissue. So this is the carotid artery is palpated. So these are the fingers. Okay. So the carotid pulsation is just palpable just lateral to the groove formed by the trachea and surrounding soft tissue. So the quantity of subcutaneous fat will dictate how firmly you need to push. So the quantity of the subcutaneous fat will dictate how firmly you need to push. The pulsation should be easily palpable. Diminution of the pulsations, they may be caused by atherosclerosis, aortic stenosis, or severely impaired ventricular performance. So diminution of this carotid pulsations can be caused by atherosclerosis, aortic stenosis, or severely impaired ventricular performance. So do not push on both sides simultaneously, as this may compromise the cerebral blood flow. So don't examine for carotid artery on both sides because this will compromise cerebral blood flow.